Good morning, good afternoon, and good evening, everyone, wherever in the world you may be joining us from today. My name is Francesco Del Carpio, and I am the CFL York Operations Coordinator. I would like to officially open the third session in our 2026 Emergency Management in Hospitals and Healthcare Speaker Series, presented in partnership with the Thunder Bay Regional Health Sciences Center. I would like to begin today with a land acknowledgement. First Nations peoples have lived on this part of Turtle Island for millennia, stewarding the land, the water, and all that contributes to life in this region. Today, the culture and presence of First Nations, Inuit, and Métis peoples enrich the lands and people of this territory. More than 2 centuries ago, the Mississauga people welcomed settlers to this territory, providing sustenance and engaging in trade and commerce. Between 1781 and 1820, 8 treaties were signed with the Mississaugas of the Credit First Nation, who opened their territory to settlement. Today, York University's Keele campus is located on Toronto Purchase Treaty Number 13 lands and is situated on the traditional territory of the Huron-Wendat and Haudenosaunee. Treaty history is foundational, and it is our collective responsibility to honor the land, as we honor and respect those who have gone before us, those who are here, and those who have yet to come. We are grateful for the opportunity to be learning, working, and thriving on this land, and we commit to learn the truth and be active in the process of reconciliation. As this is an online event and our participants may be joining from various locations, I strongly encourage you to learn about the traditional land upon which you are located. With this, I welcome our moderator, our speakers, and our participants from around the world. Welcome to our webinar. It is now my great pleasure to introduce Misha Richard. Misha Richard is the current Emergency Preparedness Lead for the Thunder Bay Regional Health Sciences Center in Thunder Bay, Ontario, Canada, and has been our partner throughout the entirety of the series. So we thank you very much, Misha, for all of your help in putting together the series and in moderating the session today. For the sake of time, I will be putting everyone's complete bios in the chat for your reference. But for now, I will hand it over to Misha to introduce our panelists. Thank you very much, and the floor is yours.
Hello, everybody. Thank you for your patience in us getting started just a little bit past our normal time this morning. I'm excited because we have 3 speakers with us today that put up their hands to be able to take part in this session around hospital command centers and emergency operations centers. A couple of them are familiar faces, but I'm going to start with a new face to our series, which is Courtney Carroll. So welcome, Courtney. She's the manager of risk and policy at St. Thomas Elgin General Hospital in Ontario. She brings over a decade of experience in health, safety, quality, and emergency management within the healthcare sector to this talk. I'll give a shout out to Kassondra, who has finally been able to get onto the panel with us. So happy we got over the technical issues. Thank you. Cassandra Stockman-Sousa is the Emergency Preparedness Advisor at Halton Healthcare, which she joined in 2013. She's worked in the field of emergency management since first beginning her career at the Office of Public Safety and Emergency Management at George Washington University in the States. And since then, she's held subsequent positions in organizations of higher education and regional government. And then welcome back to Andrew. Andrew Moull has been a dedicated professional in healthcare emergency management since 2014. He currently serves as the manager of emergency and disaster management at Hamilton Health Sciences in Hamilton, Ontario. He's also a co-course director at York University's Disaster and Emergency Management graduate program. So thank you all for being here. And before I open up the microphone to all of you, I have some slides to kind of run through for those who are joining the session, perhaps some that don't come from a healthcare background that might be curious about what some of these distinctions are. So give me 1 second and I will get the screen up for you. Perfect. So hopefully you can see my screen. If I can get a thumbs up from one of my fellow presenters there. Perfect. I've got 2 thumbs up from Andrew, so that's great. So as a really quick overview for everyone on the call, what's a hospital command center? And I think it's worth mentioning the NASA mission control today, given our lunar mission. So shout out to everybody else that's a bit of a space nerd, not just a healthcare emergency management nerd. So we always think of this image when we think of command center, I think, where you're seeing this kind of centralized location where your leadership's getting together and they're doing that day-to-day coordination of operations or potentially a very important mission. Now, we'll talk a little bit more about coordination of day-to-day operations in one of my later slides, but I just wanted to touch on, okay, so what's a hospital command center for the purposes of our conversation today? So this is the space that's not necessarily set up as your day-to-day operations. It could be, we'll talk to our panelists about this, but it's the location where your organization is working to coordinate the response and recovery activities, your resources, your information. So when you hear HCC, that is a fairly common term in healthcare. And where it comes to a comparison is what it gets used for. So we'll talk about this in a second, but could be proactively set up. So thinking of some of our peers that are working towards being better positioned to deal with FIFA, for lack of a better term, might be set up for public health emergencies. So you think of something that's like a regional infectious disease outbreak. All of us that went through COVID while working in healthcare could be set up to support in managing an actual emergency that may or has the ability to overwhelm their operations. And where you'll see some of this similarity in how we're doing things is with an emergency operations center, which might be language that some folks on the call outside of healthcare would be more familiar with. Tends to be used in government community settings, but it gets used elsewhere as well, right? So some hospitals use the term EOC, some use HCC. This is just an overview to kind of familiarize you with both. The terms that I'm pulling up here are from Emergency Management Ontario. So again, just recognizing sort of that government definition of how this space is used. But essentially, EOCs provide support often to an incident site. So they view it as tied back to incident command system, incident management system. But we're not here to talk about how you structure your emergency management team as far as staffing that group to respond. We're talking about the space that we use. So you use the space for coordination, a little bit more rarely command role, vary in size and staffing. Certainly, a smaller community or smaller organization might just staff up when needed, and others are very large spaces that just have permanent staff that are consistently working in that facility. So what do the accreditation standards say about this? I feel like it's always worth mentioning. This is something that all the hospitals in Canada have to go through, and the US as well. I'm looking at the Canadian standards, so just wanted to put this up as a highlighted note to everyone. So one is in the emergency and disaster management standards that you're supposed to have some sort of emergency management system. So that's what I was mentioning before about using incident command system, incident management system, for example. The key piece here is the following section saying that we have to designate a location where this coordination is taking place. So business continuity, response, recovery activities during and following an emergency or disaster. So we're supposed to have this space. We, in kind of the guidance for this, are advised to have a physical or virtual location, which can be referred to as an emergency operations center. So that's where we're getting kind of that overlap in our terms, of course. And this is where the emergency management team, and however you have predetermined that structure of staffing, is going to coordinate the emergency or response, and that you may also have a designated backup location. So hopefully everybody's with me on this, whether you come from emergency management in, banking or municipality or healthcare like the rest of us. This is what we're advised to have in healthcare. And you can see how there's a lot of overlaps in clearly how emergency management is coordinated in different organizations. So the wave of the future, I would be remiss if I didn't mention something like we talk about NASA's control center, and that's where all these day-to-day operations are happening. Well, there's a few hospitals that have kind of been spearheading the fully digital format. So Johns Hopkins was basically the first that I'd come across, and I can't believe the amount of time that it's been. I mean, it's been more than a decade, I think already, since they went into this space. So they refer to it as being the inner brain. This is staffed all the time, not just when you think you might be impacted by some sort of hazard, not during an emergency response. It is the command center where all of the control of the flow of patients from the moment they arrive to the moment they're discharged. This is a huge hub. Another location that's spearheaded this from the Canadian perspective is Humber Health here in Ontario, is also into the digital hospital space, where you have a hospital command center, with that term meaning this is where all coordination for the hospital is essentially taking place as that digital hub, regardless of emergency or not. Okay, so hopefully we're all, again, on the same page. Now I'll get into just a couple of questions. I'm going to throw them up on the screen, and then I'm going to take them down. And then I'm going to pose the questions to our panelists, because we've got a few. So one is kind of thinking about, do you have a centralized location? Is it the same space where you're doing your day-to-day operations? What might trigger its use? When would you not use it, even though an emergency is taking place? Thinking of virtual hybrid as an alternative. How do you resource this space? And who's actually responsible for maintaining it? You know, who goes in with the feather duster and cleans this place up? So I wanted to bring all of that up, recognizing we're going to get more questions from folks on the line. So I'll stop sharing my screen. And with this consideration of folks, I'm already seeing some questions going into the chat. If you have questions that you would like the panelists to address, please use the Q&A function. We'll do our best to moderate that so that we can get those questions directed to the right person or to the panel as a whole. So I'm going to start off with just a little bit of context, because Andrew, Courtney, Kassondra, you're all dealing with very different organizations. My organization has one acute care facility, and then we have some medical and IT spaces that are in different, more office-style buildings. And we do obviously have staff that are dispersed and working within the community. But for the purposes of kind of context to everybody on the call, we have one primary hospital, and that is where our one facility for this purpose is located. So now we'll turn it over for whoever just wants to share a little bit of what is the structure like, you know, how many buildings, how many hospitals are part of your consideration before we get into what facilities do you have to support that emergency coordination at those facilities. Andrew, you're the first one I can see on my screen, if you want to jump in and tell us what your setup is like.
Yeah, certainly. So our organization has five acute sorry, four acute hospitals, one non-acute hospital, and we're still maintaining that hotel from COVID as well. And then on top of those more acute, providing care, direct care to inpatient facilities, we also have the Ron Joyce Children's Health Center. We do have several office buildings. One is on the campus of the general, which is our main trauma center. We have a research center that we co-run as well, that's on that campus. We, for now, at least for the next couple of months, do have 3 floors of an office building in downtown Hamilton, but we'll be relinquishing that lease soon, so it won't be my problem anymore. Anyone who knows Jackson Square can pick up on that. And then we have an urgent care clinic as well. And then we have a couple of doctors' offices around the city that kind of look after themselves and are fairly self-sufficient. So are we going more detail on how we have command structures set up, or
Get into that
did
in
you
a
just want kind of the
second.
org structure first?
So you've got lots of different buildings basically to worry about, is the long and
Yeah.
short for folks. I can send it back to Courtney, because I feel like you're in a situation that's a little bit similar to my organization. So if you want us to tell us a little bit about what your group is like.
Oh, thanks, Misha. At St. Thomas Elgin General Hospital, we are an acute care hospital. And so we are basically one building. So I only have one building to worry about. We are a 173, 176 bed hospital. So we don't have all of these different other facilities to worry about. It's just under one sort of building umbrella.
Okay. And then it goes to Kassondra, where I know you're in more of a similar boat to Andrew. So give us a
Yeah.
little bit of that 30,000 foot view of what you guys are overseeing.
Okay, so we are three community-based hospitals, all ranging in very different size from Oakville, our nice new one up here, down to our much older rural site in Georgetown. And then we have several community-based locations as well, including a dialysis group that's actually in Burlington, that we actually run out of a Joe Brandt hospital building. So that one's a little bit of a different connection. But yes, that's kind of a jits of my area.
Okay. So now that everybody on the call recognizes we've got some variance in what we're overseeing. So the thought of having one room where everything takes place might be possible for myself or Courtney. I'm going to assume with Andrew and Kassondra, there isn't just one facility where coordination can take place. So I can see Andrew doing a little bit of the head bob there. So do you have sort of a corporate command center and then like a site level EOC or hospital command center? What do you guys have?
Yeah, so for us, we do have a dedicated corporate. It's funny when you mentioned using both hospital command center and EOC. We actually use that to delineate between the site level command center and kind of it would be the equivalent of an area command at the corporate level for those non-healthcare folks, if you want to equate it to that. So our senior leadership team, or SLT, does have its own command center, and within Epic or your EMR, you can get dashboards set up again for that 3,000 foot view of what's your site capacity and if you need to get down to the nitty gritty and certain dashboards, you can do that as long making sure I'm going to say 9 times out of 10, you probably want to have your EMR specialist in the room to help with that. So in a way we do, and then we do have site level commands at each site. And then we have hospital command posts, which if there's I'll say a physical incident, it would be like your charge nurse desk would kind of be that frontline equivalent.
And then Kassondra, I saw you kind of nodding. You have kind of a similar setup to Andrew. Do you want to share how many
Similar,
facilities
but
you
we
have?
do not use the same terminology as Andrew. So we actually have a daily command center that is in full operation, that does the patient flow and things like that. So they call that the command center. So we do call our stuff the Emergency Operations Center. Partially as well, we do follow provincial IMS, which is the term they would use. So that just ties in with our stuff. We have our corporate emergency operations center here at Oakville Hospital, and it would be used should we have an event that's impacting all 3 hospitals. It would be the top level, but it's also where we might run our corporate impacting events, like a full ICT outage that's impacting all our sites. We would most likely run out of our Oakville location. But then all 3 of our hospitals do have their own emergency operations center. So if it's a Milton specific event, we may set up at the EOC there at Milton, as opposed to coming to this one. And then we do have the choice for virtual, using our new Teams EOC on Teams that we've created. So that's our other option that we have used.
And then so Courtney, again, I'm assuming it's one space. Is it also where kind of your daily coordination is taking place, or is it separate when you're thinking about emergency scenarios at the hospital for that physical space?
Yeah, so we do have just one space that is dedicated, similar terminology to what Kassondra spoke about IMS. So use them interchangeably, but here I'll say our emergency operations center model aligns with the complexity and the impact of the incident. So rather than maintaining a fixed activation structure, we activate our EOC proportionally. Whether that's focused on an operational huddle. So we do daily huddles on each department, but then we have a weekly huddle where you can have some of the engagement with some of these in conversations about, potentially, an emergency that may be coming up or is expected. I think of pandemic, for example. We also have the hybrid virtual coordination model or a fully activated command structure. So our EOC or IMS would operate out of our boardroom that's used for meetings on a daily basis. That's what's at our hospital. One of the advantages of our size is the ability to rapidly engage executive leadership, which supports the timely decision making and strong operational coordination. So our approach, when you think about Accreditation Canada, our approach emphasizes that agility, situational awareness, and collaboration both internally and with our community partners.
So now I've heard pandemic get mentioned, and I've heard, like the network outage. So I think the next question is, when would you use this space? And alternatively, when would you not? When would you not utilize a physical space to have this coordination team pulled together? Anybody want to jump in? I know I see some deep thoughts.
I can go.
Yeah.
We just had an EOC active on Friday. So Oakville likes to set up EOC, so now that we've had one, we'll probably have another 3 in a row. We commonly set ours up so something like an ICT, which is what we had on Friday. We will set it up when it's multiple systems being impacted and having a effect across either one entire site or multiples. If it's only one system down, like if we've just lost our Meditech system, we will not set up an EOC. ICT will do their own little work downstairs and coordinate as appropriate. But it's when we're looking at multiple systems, and especially if they're not quite sure why it's happening either, so they haven't found a root cause yet, will be when we start setting up the EOC. And we're doing it a lot of, obviously, to help with the business continuity aspect of helping all the departments and stuff continue running without certain systems maintained. But usually what we look at is it has to be impacting a wide enough group and safety of some sort for us to activate a full emergency operations center. And our group does prefer in person as much as possible over virtual. We just find people work better together in a room than they do virtually. Virtual just doesn't work as great when you need to have discussions with people and stuff. So we do try to get on site as much as possible if we can. So I guess, sorry, Misha, just to say, we don't have and Andrew's probably the same, there's not like a ranking or exact, like it must meet this kind of standard in order to activate an EOC. So a lot of it is just judgment calls in the moment, and does it look like having a group together would be more useful and help with the process. Even just communications itself, is that something that would needs a little bit more support that the EOC could support?
Yeah, and I mean, outside of obviously there's specific responses that, like if there was an evacuation or if there was a mass casualty incident, right? Like there's emergencies that, yeah, we're activating. So it's fairly cut and dry. So our sites they do have daily safety briefs, which that team largely comprises. We've synced that team to largely comprise our IMS team, and they meet every day. But they're looking at more, number of falls, like their usual safety things. But if there are threats on the horizons or things to consider, like whenever McMaster homecoming in the fall, our daily safety brief will kind of go over, what that impact might be on McMaster Children's Hospital. And that sort of thing. So they do filter it in. We do empower our site directors who are, we have a few folks we've kind of tagged as like if there's something that happens, especially during business hours, these are the folks who will be the de facto incident commander unless they're away. And then we do have designated backups. But we've really empowered them to just, if you feel the need that we have to activate, feel free to activate. And largely I wouldn't say had any inappropriate activations or kind of cry wolf. And in any event, I don't want to ever kind of punish anyone for being overly cautious. It ends up just being a free drill in my eyes. So
then here's where I was going with this, is the consideration of virtual has become huge, I would say pandemic, right? Post-pandemic. Prior to that, it was just an assumption of, well, we're going to stand up, our management team. They're going to be at our HCC or EOC or HEOC or whatever we're referring to it as. But I think there's some nuance here as far as certain emergency responses. You might not want to gather all of your leadership on site in the physical space. But historically, it was kind of one of those triggers of as soon as it's an emergency, we're getting this team together. So for folks on the call, just thinking of something like, bomb threats to the facility or things of that nature, loss of power, do you gather everybody in this facility? Might be some considerations as far as does it make sense to have everybody here? But to the point of virtual, now I've seen folks putting in the chat, and I really want to encourage if anybody has questions, throw them in the Q&A for the panelists, but talking about kind of this move to virtual. So I think it's worthwhile asking, what tools are you using? Andrew, I think you had said, like Epic. I know there's various virtual platforms. Kassondra, you mentioned, your organization's pretty fulsome adoption of Microsoft Teams. What kind of tools and fun gadgets and all that kind of stuff do you have to facilitate that coordination group? I'm sure Andrew wants to talk, but I might I might move around a little bit. So Courtney, Kassondra, which one of you wants to talk about what you use before I go back to Andrew?
I'll go,
Courtney?
I'll go, Misha. We don't have a lot of fun gadgets like Andrew has. We have adopted Microsoft Teams, and I would say that, like I was saying before, it is a scalable response. It's a proportional activation, and it also involves our leadership engagement. So like Andrew was saying, how he's empowered his directors and leadership team, we have managers on call and executive leadership on call, and we really empower them to make those decisions to whether or not to activate and how they would activate and the support that's available to them. So we do meet via Teams often. It's not always in the boardroom. It's dependent on the scenario and the situation and how quickly we need to bring people together. And sometimes Teams affords us that opportunity.
Kassondra, similar?
Yeah. So we don't just use Teams. We have literally developed what we call EOC on Teams. So we've created a special group that has private channels for each activation. The IMS team members are added to that. All their documentations are there. There's an electronic sign-in. We use a lot of list formats. We do our major events logging on there. The incident action plans have now been developed through Microsoft Forms, so that's actually looks a lot like the provincial IMS form, but it's actually been developed into a much easier to use format, and it digitally goes to the incident commander who can make edits and then approve it digitally, and it sends back, and then we post it for everybody to have. So we really try to keep as much record keeping and everything in Teams. Right now, we're also hoping to eventually develop a private channel calendar capability as well. Teams doesn't do private channel calendars yet, so our my guru in the back at my ICT team is helping work on developing that later as well, to the point. So we will have even our operations meetings, everything booked out of this one shared calendar, so everybody will know where everybody is at one time. And then we also utilize our Everbridge system as a way to activate our teams as well. So there is a little bit of connection there. And we even learned in our last outage on Friday that Everbridge would have helped us a little bit get our Teams meeting set up because we were really struggling with the some of the slowness with the email. So I literally had to do it on my phone and enter everybody's name individually because of the way the problems we were having, where I could have just added the Teams link to an Everbridge email and sent it, and it would have worked actually much faster. So little things even just learned off of the Friday, the one that we've already incorporated into our EOC on Teams. And sorry, and the last thing I guess for that is we use it in our physical EOCs or our virtual. So regardless of how we're operating our EOC, we're using Teams on EOC no matter where we are.
I think that's a really good distinction as well, that you just made, Kassondra, which is the idea of if you're putting your action logs, you're doing, personal logs, you've got a status board. If all of that is built into your teams, but you're using it every single time, there's a familiarity there, whether you're physically gathering in the space or whether everything is just happening in an online capacity. I know Andrew's just chomping at the bit, so tell us
I'm just
about
trying to
all
clear
the
my
fun
name
stuff.
here. I don't know what special tools everyone thinks I've got access to. No, we use Teams, and we do our situational report through forms, and then we'll use BlackBerry Ad Hoc as our mass notification tool, so we can use that to activate. And our site leads, currently our site leads have the ability to, they don't need to call us to activate. They can activate the command center from their phones through the app, and eventually we're rolling it out to our on-call leadership as well. They end up calling myself or my specialist Shaylee if they need any help anyways. But no, we don't have too many special things in our I operate a fairly low tech operation on purpose. We do run a hybrid system with each meeting, largely because especially at our three large hospitals, we run a hybrid model just for almost people management. So we restrict kind of participation within the command center to directors, chiefs of staff, and maybe if there's something in particular impacting a program. And then managers, we actually want them to stay with their teams. So they'll hop onto Teams to join into the EOC. But we'd actually rather have them stay with their teams so they can kind of stay in touch. And then if they need to contribute, they can bring it up in the meeting. I don't have any special. Where are you guys thinking I've got the budget for a special?
You're just
What
ahead of
kind
the
of special
curve.
tools do you think I mean, I have stuff for training. Like we do design animated videos for training, but like we don't do anything too special for command center. But that's on purpose, mostly because until recently, especially with our West Lincoln site, two of our sites, I think St. Peter's is coming up on its 90th birthday. The old West Lincoln was a time capsule for anyone who ever got to experience it. And so you had to be low tech for those to function. And also just I don't like to anchor myself into any one room if possible, and that just comes from an experience. When I was at Scarborough Hospital, we had a fire, and that the smoke compromised our main EOC, and so we had to pick up laptops only and go to a secondary our backup space. But that made me appreciate being a bit more nimble. And tech is a nice to have, but not a must have
This is
for
a
our
good
EOC.
segue, which is, I think maybe we're just assuming for anybody that doesn't know Andrew as personally as the rest of us do, he does love his tech. So I think I was just waiting for him to say that he has some sort of robot running the entire show. I would not have been surprised. But to the point of what happens if that physical space is compromised, I think takes it to another question. So very similar to Courtney, my organization has kind of our large senior leadership boardroom. It does get booked for regular meetings, but that is the space that's been established as kind of our primary HCC location. There's the kind of the speakers, the cameras, things are set up in a way to facilitate being able to do hybrid very well, as well as some additional not high tech toys, but it's, keeping the hard copies of everything, having, a rollaway TV monitor, like having some of this extra stuff because you never know what might not work in the moment. And so having redundancy. So that's the question I was going to ask is, what does the redundancy look like for you? And before I turn it over, while you're thinking on how you'll describe the redundancies, at our organization, we realized that the boardroom that we've designated as that primary meeting space did not have backup power because it was an administrative area of the hospital. So for folks that, again, don't come from a healthcare background, when hospitals go on backup power, you might see those little red outlets when you're here visiting the hospital, and only certain things are meant to be plugged into those, and those are only available in certain spaces. So this administrative meeting space was not originally designed to have that capacity. We've since added that capacity to a separate meeting room within the organization. So at least if the hospital is running on backup power, we have an alternate location physically where people can meet. But that's been more of a recent action from the organization to build some more redundancy in physically. So who'd like to talk about what your redundancies look like? Does anybody want to jump in?
I can. Ours is pretty straightforward, and we really benefit from our size. And this actually kind of came up with our recent active attacker full scale we ran back in December. Was if this ever happened at your site, you're not necessarily going to be setting up a command center at that site. And so we could then just set up if a site was compromised for whatever reason. We obviously have rooms within the hospital that we can move to. I'm at the Dravinsky today. We've got about 3 or 4 spaces that we can take over if needed. But if, say, the Dravinsky site was compromised, we could then just move the Dravinsky command to the general site or McMaster, and continue supporting teams from there. We'd probably set up some on-site command posts, but if we needed a formal command center. So we do benefit from that, being able to stay inside. And I feel very confident as well, if all our sites somehow got compromised, that our friends at Joe Brant or St. Joe's in Hamilton and Burlington, or Halton or Niagara, if we really needed the space, would accommodate. Our one challenge with the McMaster was, and we thought it was an option, McMaster Children's shares its building with the Faculty of Health Sciences with the university. And we're like, great, there's lots of boardrooms, lots of rooms we might be able to move into. They're on a different Wi-Fi network. Getting switched over is a nightmare. And so anyone whose hospital also shares with a university building probably, I imagine, shares something similar of a problem. And it's just annoying to try and get. You might have certain individuals who have access, but to get everyone on your incident command team takes a bit of coordination, and then you've got people leaving the organization coming in, and it's too difficult to maintain. But in a worst case scenario, we know that McMaster would support, and they're likely activating their command center as well. So
it's actually a really good point. Obviously, our relationships, our peer and community contacts, that really worst case scenario, to your point, can somebody else host our coordination team if our physical space was truly compromised, or we were running with a very protracted situation. I don't know if Courtney or Kassondra, you guys want to mention any of the redundancies that you've built in? Kassondra, go ahead.
Okay, I can go. Our redundancies are we have 2 EOCs at every site, or 2 locations chosen. Our EOCs are not set up. These sites do have, our main ones do have UPS connections as appropriate. Of course, since Teams is our primary, should that be down, we do have totes with paper logs and forms and stuff ready to go. So power's covered, that's covered. We even got food supplies in them. Stuff not a redundancy thing, but we've got toothbrushes and deodorant and stuff for people that get stuck there. So we have lots of different ways to keep these EOCs running. And then obviously, like Andrew has, we do have multiple sites. So should we have to, Oakville isn't available, we can go to Milton. And then obviously we have really good partnerships with the region and stuff too, which is not that far from us. So if we ever extremely needed something else, I would contact our regional partners as well to see how they could provide space to us, because they have quite a large building not too far away from us as well.
And then Courtney, anything to add as far as how your organization structured that space? I know you're kind of similar to us. It's like there's really the one space that you've kind of dedicated attention to. People know that would be the physical gathering point. I don't know if there's anything to add on redundancies there. Otherwise, I can move on to some more stuff. Go ahead.
I we're very similar to yourself, but just expanding upon what Kassondra and Andrew have already said is we also really do utilize Teams and connecting virtually, as opposed to sometimes always just going into the boardroom, right? So the boardroom is available and useful, but we do utilize Teams. It's sort of like a hybrid. Like, do we need to meet virtually, or sorry, can we meet virtually, or do we need to meet in person? And it's making that distinction at that time. I also would like to add, from a risk management policy perspective, thinking about, do you have all of your policies that you can access when you need them, right? Whatever works for your organization, we've found what works for us, but do you have those policies for when you're going to need them? Not just always your downtime forms, but your policies as well.
Oh, 100%. Because the more we lean into having everything on our networks and doing everything with kind of that virtual capability, it's not sexy to talk about hard copies. But I mean, I keep a binder at my desk and a binder at home with all of the policies in them. And we make sure that our hospital command center also has those paper copies for all those positions. So again, not sexy, but very necessary. I would also comment one last redundancy piece before I start to ask who's responsible for maintaining all of this at your organizations. Yeah, I was waiting to see some hands go up. As I was going to mention to folks on the call, I don't know what connections you might have to community partners that can support your own hospital command center or EOCs. Here, our hospital was actually built with the intended use by the city as being a ham radio point. So we actually have radio antenna, and it's in a room adjacent to our senior leadership boardroom. And we do biannual testing with our volunteer amateur radio operators here in our community. They are lovely. They are so passionate. And they really are trying to be prepared for worst case scenario, which is that kind of our modern communication networks are disrupted and that we will still have functioning radio capability. So we think of that as well of, what are some of these potential redundancies that could make us more resilient? And one of them in this case is truly our partners being able to support us in getting the message out if needed. So who has to maintain all of this? I schedule those testing appointments, for example, but I immediately saw Kassandra's hand go up. So you are the one that's got to keep all of this stuff in order. Tell me about it.
Yes, so 6 EOCs and virtual EOC is my job on top of 20 codes. So it's all maintained by me. So they consider me, when we do activate, I'm also called the EOC manager. I'm not running the EOC, but I'm just making sure everybody's got what they need, everybody's supported, things like that. But to maintain it, except for the laptops, sorry, I should say that laptops are updated by our ICT team, but I do check in to make sure it is being followed and things like that. So it's still kind of in a way under me even then. But paperwork, making sure the team's accounts are still going, things like that, that's all under me.
Okay, and Courtney, Andrew, who is in charge of maintaining this physical and virtual space for these teams to get together? Andrew.
So our department oversees, but we actually do work with the site directors, admin assistants have been absolutely invaluable in helping us out. So if we need any additional equipment or anything, we recently did a big buy on additional. We felt we needed more power bars and USB-C and spare Dell laptop or HP laptop chargers. They are the ones who kind of coordinated that. They do check in on the supplies. And so they maintain the room, so to speak. We do run quarterly command exercises as well. So everyone kind of operates, we knock on wood, and on too many. I'm not saying that with, I try not to jinx anything, but having those regular quarterly exercises, and leaders have started rotating who's in the physical command center as well, just to get familiar with the space. We recently did identify at our St. Peter's site a need for more whiteboard or more whiteboards to be put up in the room. So our admin assistant for that site will help take care of that. So we coordinate, we do the online Teams command, but for the physical command center, we do have a wonderful relationship. And I encourage everyone, if your admin assistants are not on your Christmas card list, you have some work to do.
Yeah, if you can't see us all, we're smiling and nodding because I will also give them a shout out for all that background grunt work that they do on this front. Courtney, are you the sole person that must maintain the space, or is this kind of a shared effort in your organization to keep it all up to snuff?
Yeah, because we have that flexible EOC model and our size allows for that rapid communication and decision making without requiring a full command structure for every incident, and activating our full EOC unnecessarily. It really is a cross-departmental coordination, right? So it's not just me, it's not just our executive assistants. They are, like Andrew said, they should be on your Christmas card list, but it's definitely a team effort. And I think that the size of our hospital, we need to operate in under that capacity. So it's not just me maintaining it. That probably would be a full-time job if I needed, if that was the case. So definitely cross-departmental coordination.
So I know a couple of you mentioned some experiences. Obviously, Kassondra's is the most fresh in mind. But are there any lessons learned or additional takeaways about how you're structuring either the virtual or physical command center based off of recent incidents or exercises that you've run? Any takeaways that you'd like to share with those on the line? Andrew, you're unmuted. I don't know if that means you're stepping forward.
Sure. Sorry, I was just typing. There was a question in the chat from Corey around our quarterly exercises. So I feel like this probably fits in.
Perfect.
Well, no, Cass had an activation on Friday that I'm sure she talked about. But in terms of so just very quickly, I don't want to take too much time. The quarterly exercises, the main goal is never about the scenario. It's about the objectives of that exercise is to be familiar with the command center and the our version of IMS, which is really just we flagged that getting the initial incident action plan and getting the ball rolling was always a hurdle. And so that's what we've prioritized. And I'm very happy to say the results since we launched this about a year and a half ago. We've already seen dramatic improvement where my specialist or I are just kind of sitting in the room, not really advising because everyone's following the incident action planning process. They're a lot more comfortable. They're able to set up the room if needed. So what we do is we send an alert out half an hour before the scheduled exercise. It is scheduled. I don't surprise my directors and leaders yet. That might come down the pipeline, but you don't want to, and VPs and physicians do participate as well, which is fantastic. And so, but we almost come up with a scenario 35 minutes before the exercise. Again, it's not the priority per se. And then they meet, they assign roles based on the scenario and who's in attendance and who is able to attend. And then we kind of go from there and set up, do an initial action plan. We schedule it for 60 minutes. Lately, we've been running 20 minutes because they're able to kind of go through the process. So we're actually now at a point where we might adjust it to kind of meet new needs. But
So Andrew, based on this point though,
yeah.
is the actual EOC space or virtual space being utilized whenever you're running these?
Yes.
Yes.
Yeah. So
Okay,
we
just
do
clarifying.
we do three in-person exercise, a hybrid, because the base is hybrid. So we do three hybrid exercises and one virtual a year. And one of those four is also going to be, we do now an annual all hands on deck exercise where we stand up all 7 command centers simultaneously to respond to some large corporate threat, with the goal of trying to communicate and share information between the sites. And that also really works our senior team to get the information organically from the site commands to feed into the corporate. So, which that's worked really well.
Obviously very impressed at your exercise schedule and your looping in of this space. Kassondra, are there any big takeaways that you haven't mentioned related to past experiences that connect to the usefulness of this physical or virtual space?
Yes, so we did have lots of lessons learned. Last year alone, I think we set up 6 or 7 EOCs. So we got through lots of experience last year. And wide range of the reasons we set up those EOCs. So a lot of it was people that weren't actually even trained to be in the EOC caught us by surprise when they ended up being the lead in operations. So a lot of little things have really been discovered. I would just say one of the biggest ones we did was because we used the provincial IMS, we used the incident action plan for them, the consolidated one. So if anybody's ever seen it, it is a horrible Word document to try to fill in. And so the number one thing I'd done was try to make that easier on my planning chief. And that was probably the biggest thing when some of them came in for training, they'd had the experience with the old system. They were just so excited by this new Microsoft form. It was kind of funny, but they said, what a difference, just having something so much easier to fill in that isn't size restrictive and things like that, doesn't require formatting on their end. So every time, obviously, we've done an EOC setup, we do a debrief, and that's where we get a lot of our lessons learned. We obviously have not had our debrief yet from our Friday event, but even just little things I'd already discovered, like that Teams problem, sending out a link for some meetings. I've already rectified at this point. So I don't always wait for the debrief if I've already discovered something that could make it easier for everybody. But I think our biggest one is that we've done virtual. We've done in person. People just work better in person. There's a lot less struggle because people support each other better when they're in a room together than when they're doing it virtually. So we do try to bring the most of the people on site, some like finance and things like that, don't necessarily need to be in the rooms at all times. So they may join by phone or through the hybrid setup. But otherwise, that's probably one of the big things we do push is we do try to do more of a physical response if we can, obviously, without violating safety. But even when you said like things like a co-black, we'd probably still do in person. We would just go to the site that's not impacted by the event and run it physically over there. So we have that advantage.
I realize we're basically at time, but we did get started a couple of minutes late on today's session, so maybe everybody's okay with a couple of minutes over time. I don't know, Courtney, if there's any examples from exercises or real events or perhaps even participation with community partners where you've got joint EOC activations. If you wanted to add, I didn't want to ignore you on this question.
Yeah, so I think of it in two different ways. When you think of the pandemic, we activated our EOC almost daily, right? And so meeting in that boardroom. And I get that might have been a couple of years ago, but that was a big activation for many hospitals, right? And how do you meet and how do you scale your response? And is it going to be virtual? Is it going to be, and sometimes it was virtual, right? Or is it going to be in the boardroom? I also want to take you to, when you think of respiratory season, and I get that it's not an emergency code, so to speak, but if you think about us and, surge incidents, we if we feel that the capacity is changing, right? So our capacity to handle patients coming in is changing, then we have a policy that's set up for the surge capacity, and then we activate an EOC virtually at a time on that day to ensure and coordinate bed capacity, staffing, patient flow, et cetera. So I think it's important to think about, you can activate these EOCs for for emergencies, but you can also activate them in a different capacity that also feeds into your emergency planning and preparation for if there was an emergency to happen.
I think that's actually a perfect concluding thought. So I'm glad I went back to you, Courtney. That proactive stance of why, in some scenarios where we have a bit of lead time, are we waiting until we're really in the thick of it? And now we're trying to call in the Cassondras of the world to make sure that a certain piece of technology is functioning, or that there's 3 new members that have been called in to support the response that haven't actually been trained on how to make use of that space or how to take part in a hybrid capacity. So I think, again, great point. These spaces are where we're getting together to coordinate any sort of response that's outside of our normal capacity. And you can stand it up for one day, have one meeting. It can be something that is long running, like our COVID response. So just recognizing that. And obviously, all 3 of you mentioned multiple times about the flexibility and scalability of what this is. Is it a few people getting together at a predetermined platform that has some of those resources for an initial kind of meeting? Does it become a larger group where you're having to call people in and have that on-site gathering? So hopefully for those on the call, we've been able to address the questions that you had. I know there was a lot of conversation, and I think some folks swapping contact information in the chat today. Maybe this is one of those topics that we can come back to in the future, because we're always learning things from our use of our command teams being in these EOCs and HCCs virtually and in person. So we might circle back to this. But as a concluding note from my standpoint, I really appreciate Courtney, Andrew, Kassondra, you guys coming forward and being willing to share. You all come from very different backgrounds in this. And again, I think everybody, based on the amount of dialogue in the chat, really appreciated you taking part and speaking on this subject today. So thank you very much. Francesco, a few closing words?
Yeah, thank you so much, Misha. And thank you again to everyone, to all of our panelists today. It was a great discussion. Thank you, of course, to everyone in the chat who joined us for the session. And like Misha said, for being so active. I think this is one of the most active groups in our speaker series. So it's always great to see everyone chatting and exchanging information. Just a couple of reminders before we close off. The session is being recorded and it'll be up on our YouTube, hopefully by the end of the day, if not tomorrow. This is a monthly speaker series, so we do have another session coming up on May 6th, so please mark that on your calendars. And if anyone hasn't registered yet, but they might be interested, please send them the link. Registration was always open and free until the end of the series. And with that, I think just one last big thank you to everyone for being here today and taking the time to join us. Oh, and I did share my email address, which I will do since there wasn't much time for Q&A and some people had to leave. If you do want to follow up with any of the speakers today, please send me an email there and I will pass the questions along as appropriate. So yeah, with that, thank you so much and I hope everybody has a great day.
Thank you, everybody.